Good afternoon, everyone. Today I shall be presenting a case series on accidental impacted large organic foreign body in the orbit with survival of eyeball and vision. I have no financial interests. Now, as we all know, intraorbital foreign bodies are a common complication following ocular trauma. Foreign bodies may be lodged within the walls of the orbit and cause damage to the eyeball and surrounding ocular structures. Here we present a series of 8 cases where all of the patients had a retained intraorbital non-metallic foreign body after trauma with preserved vision in the affected eye. Our objectives were to evaluate the surgical outcomes of removal of the retained intraorbital foreign bodies, to assess the pre- and post-operative vision, ocular movement and lead excursion, and to look for any recurrence of orbital cellulitis, infection and pus formation in the orbit. This was a prospective non-comparative interventional study of 8 cases over a period of 1 year. All the 8 patients were of the pediatric age group with mean age being 8 years. Meticulous history taking is necessary to determine the exact mechanism of injury and the nature of the orbital foreign bodies, and then we perform the radiological imaging, namely non-contrast CT scan and MRI of the orbits. The pre- and post-operative visual acuity, extraocular movements and eyelid excursions were recorded. The management outcome and long-term prognosis was studied for a follow-up period of 6 months. In this series, the orbital foreign bodies were all in the extraconal space, with 3 being in the superolateral quadrant, 1 in the superomedial quadrant and 4 in the inferolateral quadrant. Here we can see one such patient with an orbital cellulitis following an intraorbital foreign body in the superomedial quadrant of the left eye. The axial view of the MRI shows 2 parallel hypointense shadows in the medial orbit. The patient had a history of an injury with a wooden stick, so probably the wooden stick upon entry and impaction in the orbit got broken into 2 parts. The coronal view of the MRI shows the same in the superomedial orbit, and this is the view of the sagittal section. This is another patient of a history of a date palm thorn injury in the inferolateral orbit. We can see the coronal section of the CT scan showing an hyperdense shadow in the inferolateral orbit, and this is the view of the sagittal section of the same patient. The preoperative localization of the foreign body was possible due to the meticulous radiological examination, and subsequently all the patients underwent minimally invasive orbitotomies for the removal of the foreign bodies. The mean length was 30.5 millimeter of the removed foreign body, and in all of the cases the foreign body was accurately located and removed. Thankfully, the visual acuity remained unaffected in all of the patients, and all of them regained extraocular movement completely and LPS action post-operatively. Here is a short surgical video of 2 such patients. The initial surgical site is marked upon the proposed incision. The skin and subcutaneous tissue is incised by radiofrequency knife. Then the orbicularis and the orbital septum are dissected, and we enter into the extraconal space. Blunt dissection is carried out, not too aggressive, and upon reaching the foreign body by feel or by visualization, we remove the foreign bodies in toto. In the left we can see the bamboo thorn, the date palm thorn that was removed from the inferior orbit, and from the right side we can see the 2 parts of the wooden stick that got engaged in the superomedial orbit. Subsequently, wound toileting was performed, thorough saline wash was performed to remove any debris, and the wound was closed in layers. The initial incision, the initial entry site was remained unsutured. Orbital foreign bodies are more commonly observed in males and in younger patients, and thus pose significant diagnostic and therapeutic challenges. It is essential to determine the location, number, size and type of material, which significantly affects the management and potential complications. The clinical outcome also depends on the severity of the inciting trauma and the time duration from the injury. In this series, thankfully, the clinical outcome and anatomical and aesthetic appearance of all the patients were highly satisfactory. Thus, the take-home points are that if the foreign body is metal or glass, and if small size, it may be asymptomatic and may be left in situ and observed following conservative management. However, if the material is any organic matter like wood or vegetative matter, it elicits an intense inflammatory reaction and it needs to be removed urgently. Thus, it is essential to early detect the location, the size, the number and the type of materials, as this affects the further potential complications. And if the material is organic foreign body, the early surgical intervention needs to be carried out, and we should have the patient on regular long-term follow-up, as the complications may occur even months later. These are my references, and I thank you all for your kind attention.
Thank you, doctor. It's a nice presentation, but I would like to add something. actually ask. First thing, why you say all metals can be left behind? What's your idea behind it?
No, madam, I'm saying if the metal foreign body is small in size and it is not causing significant side effects, it is not causing any traumatic neuropathy, it is not causing any, I mean, chalcosis or any siderosis, then we can observe, and if necessary, we can remove, because the surgical procedure also has some complications. If not necessary, we shouldn't aggressively perform surgery.
No. I want to ask you the rationale behind it. See, why we can leave behind a shelter or some particles from a rifle or bomb shell, but not a very dirty nail inside? The rationale behind it.
There might be the Clostridium infection, and there might be the subsequent infective particle. If it is the gunshot injury, there will be high velocity injury, and as a result, the any type of infective material or organism which might be present will get sterilized. The metal particle will get sterilized, and thus it might not cause a significant inflammatory reaction.
So I think you should modify your reasoning that only maybe gunshot or a bomb blast, high velocity, very high volatile material can be sometimes left behind.
Okay.
Very rarely, pellets, etc. But you cannot generalize as it all metal foreign bodies.
Yes, madam.
And secondly, sorry, one more. What is better, MRI or CT scan for wooden foreign bodies?
For wooden foreign bodies, ideally we should both the non-contrast CT scan will show a hypodense shadow in the region of the orbit, but in the MRI I don't think we can accurately see, so I'd say CT scan.
And about glass?
About glass?
Yes.
Glass, both, I think MRI will be ideal for glass. I'm not sure.
Sir.
No. Okay, so I just wanted to know two things. What is the maximum time period between the presentation and or the injury and the time that you intervened?
Actually, the patients are being referred from the distant centers, so we intervened as soon as possible. As soon as the patient were referred to us, they presented to us, and then we could get our anesthetic workup done as soon as possible. For the minimal anesthetic workup needed for emergency surgery, we intervened. But in this case series, the maximum intervention was done within 5 days. The maximum 5 days.
And what is the mean period? I mean, most of your cases were...
most of your cases were within 3 to 4 days.
3 to 4 days. And what is the longest follow-up you have?
We have done follow-up for 6 months.
So we